So I've given this talk now several times. I'm going to zip through a lot of these slides. Some are more important in my opinion, and some are less important, but let's dive right in. So we're here tonight to talk about erectile dysfunction. Old days, we would have called it impotence, which is a bad word now. It's not politically correct. But let's dive in. Erectile dysfunction. These are just some resources here that Boston Scientific has for you. They have a website called edcure.org. You can look there, but just to plug my own site, I'm going to want you to mostly go to my site, which is dcurology.net. That's a younger version of me. This is who I am. And many of you may know me as somebody that may have even performed robotic surgery on you. That's kind of my claim to fame. But I've kind of I dove into the area of prosthetic urology, helping a lot of the problems that occur from prostatectomy surgery. So I think I'm in a good position to try to help my own patients with some of their erectile dysfunction and urinary incontinence. So let's dive into erectile dysfunction. So let's just talk about what is it. What impotence is I can't get it up at all. I can't get an erection at all. And when Viagra came out, Pfizer did its best to try to expand its market and create a new term. They're really the ones that created the term erectile dysfunction because they wanted to try to capture any man that's having any problems with his erections. So and it's important for people to understand now that there are pills and there aren't just more aggressive ways to treat erectile dysfunction. I think it's an appropriate thing to introduce the concept of erectile dysfunction. You don't have to, if you get an erection but you lose it, you still have erectile dysfunction and you're still not happy. So this is sort of a definition that it's not good enough to have sexual intercourse, but what if it's not good enough to masturbate with? Does that count? It definitely counts. Important to talk about how common is it. These are kind of quotes and kind of standard things that people kind of throw out there. But what I like to tell people is it happens to practically everyone. That's something that men don't understand. It's a part of life. It's a part of aging. So when I'm talking to men that are older, commonly maybe I'm talking to them about their erections because they're going to have a prostatectomy, something like that. I'm already talking to them assuming they don't have good erections if they're, in their 60s or 70s. So one of the things to recognize is it's just part of getting older. There's a lot of things that go downhill. Your erections go downhill. These are some statistics that kind of give you a sense of that. Let's talk about how you get an erection. The bottom line is your brain says you want to have an erection. You're horny. It goes through your spinal cord. It tells your penis basically to increase the blood flow, increase the arterial blood flow. So have blood go into your penis. So when you're aroused, the nerves are going to say, hey, let's dilate the arteries and get more blood flow. And then through a mildly complex mechanism, if you look at this, and this is sort of someone has cut off this man's penis and we're looking straight into it. There's what I call this a triple-barreled shotgun. These are the ones that are important, the barrels that are important. You urinate through this one, so it's a little less important. But if you see, there's mostly arteries inside the shotgun barrels. When they fill up with blood and get hard, the veins are kind of around it. So it's almost like a tourniquet. Arterial blood comes in and it pushes on the veins so blood won't come out. Okay, so if you can have so the number one reason, the absolute main reason why men start to have problems with their erections is simply that their arterial blood flow is not as good as it was when they were younger. When people understand that, it doesn't mean that they are about to have a heart attack. It doesn't mean that they're in bad shape. But I always say to patients, you don't commonly see a 60-year-old winning the Olympic marathon. It's because their blood flow isn't so good. So if you don't have good blood flow coming in, that's the main reason it won't be hard enough to stay good. There are some other more rare reasons where the veins won't compress properly, but all the things we're going to talk about later, age, obesity, diabetes, smoking, those are all things that affect the blood flow coming in. So I guess this is trying to show that the veins are compressed. So blood comes in, gets compressed, won't come out. And then actually, once you ejaculate, your spinal cord then actively tells your penis, no more blood coming in. That decreases that tourniquet effect. Blood comes out, and then your erection goes down. So it's all kind of modulated that way. So obviously, we can add to the spinal cord injury patients might have trouble. So this is a slide talking about some of the things we've said. I'm going to say vascular, 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 vascular. It's a function of blood flow. Diabetes affects blood flow. High blood pressure, some medications affect blood flow, but mostly it's just an aging phenomenon. Most men kind of don't want to admit that. That's usually the first step, is just to say, look, it's no big deal. It's just part of getting older. Let me embrace it and help myself. There's a lot of men that really struggle with the concept that it's a sign of getting older. So very commonly people will try to blame medicines. They'll blame lots of things. And really what the urologist is just hearing is it's just you're getting older, no big deal. I'd like to add something to let's point out physical causes. I'm not sure if there's going to be a slide later, but there's many, many, many psychological causes. I see men going through a divorce, they have problems with their erections. If they're depressed, depression is an enormous factor in erections. Mood is a factor in erections. So we're going to talk about the physical causes here today, but psychological causes, that's really a huge thing that we see. Sometimes the treatments are the same. The reason I'm probably such an expert in this and why I have such a special spot for this, because I want to help the people that I have caused the problem, is obviously all prostate cancer treatments to some degree will cause problems with your erections. And so that's the point of that. I'm just going to gloss over this to just say, again, the classic person that says, I don't get an erection at all. I'm a young man. I've lost my erections. I'm in bad shape. Diabetes is a classic culprit. So when I see men that are not taking care of their sugar, I just had a relative who he wasn't taking care of his sugar well. If they need any motivation, I can explain to them that if you're going to not take care of your sugar alongside all the other terrible things that happen with diabetes, you're going to lose your erections too. So I think that's just good enough to say diabetes is a cause. But again, anything that affects your blood flow is going to cause that trouble. Okay. So let me just kind of dive through this. And I guess, this is just talking about if you have diabetes, what are the things? I mean, again, talking about blood flow. So you could say these are risks with diabetes, but aging, of course, this is bad diabetes, but vascular disease is aging. Treatment with medications for water pills is aging. Heart disease is aging. So in reality, it's all the same thing. It's an aging phenomenon. Again, pointing out that that shouldn't be a surprise to you at all, that older men that have problems with their erections probably also have heart disease. Is it a one-to-one comparison? No. But if the problem with your erections is that you get poor blood flow, of course, they'll say, well, that could also mean maybe you'll get bad blood flow to your heart. But again, I like to go from the 20,000 foot view to say, yeah, as you get older, you just don't have the same blood flow anywhere. But there is this, awareness. Some papers came out trying to get people to be aware that if you have heart disease, you could have problems with your erections. But if you have problems with your erections, maybe that's a sign of heart disease and you should go get a physical. This is really just, I guess, pointing out, look how small the penile arteries are. So if you're going to have problems with your blood flow, maybe the penile arteries are going to be the first to show a problem. I think that's the idea behind this slide. So let's look at these things. Obviously, this slide is talking about, risk reduction for heart disease. This is why I probably wouldn't be presenting it this way in terms of heart disease, but let's see what this affects. So you could say this affects heart disease, but how about we say blood flow in general? Okay. If you eat a healthy diet, you probably have a better blood flow because you have less atherosclerosis. If you exercise and work out every day, basically like I do, you're going to have better blood flow. If you're not obese, you'll have better blood flow. If you don't smoke, you'll have better blood flow. And if you reduce stress, which really means don't have hypertension, you'll have better blood flow. So whatever you want to make your blood flow better, that's what you want to do to improve erections, or try, more importantly, to halt their demise. This is a topic that I'm just going to gloss through quickly because I don't entirely agree with what the slides say. When I talked before about how sometimes it's very hard for a man to take, that in essence, their aging is just the problem here. With aging comes, and I'm 56 now, so I can, with aging comes lots of things. But with aging comes, I'm tired at the end of the day. I annoy my wife because I can't make it through 10 minutes of a streaming series that we're watching. I'm not as interested, in having sex every day as I was before. I don't have problems yet with my erections, but one day I will. And if I didn't really realize that all of this just comes because I'm older, there has been a kind of a creation of a market of saying, no, it's not because you're older, it's because you have low T. It's another pharmaceutical term, and it became popularized. So generally, erections do not have anything to do with testosterone. So when a patient comes to me and says, I want my testosterone supplemented, I already know that he's really saying I'm having problems with my erections. And he wants to say, but it's not because I'm old, it's because I have low T. And I usually try to put them right on track to say, well, why don't we get you erections first, and then we can worry about low testosterone. Now, there are people that have extremely low testosterone, and there's something wrong with them. But the average man that says I have low testosterone has a number that's just below the limit of normalcy. Usually is unhappy because mood affects testosterone. And so I try not to kind of look at testosterone as the cause there. So I'm going to kind of zip through this because it's something I think needs to be de-emphasized as a cause of erectile dysfunction. I go straight to getting a man an erection, and I normally don't hear about his testosterone after that because then his problem is solved. Now we can talk about certainly erectile dysfunction and prostate cancer treatment. And, surgery is a big culprit. Radiation is certainly a culprit. These days, most people that get radiation also get what's called hormone therapy. And that actually makes your testosterone zero. So that's where that will affect your erections. And so they tend to have a harder time with erections. If you've had prostate cancer treatment, this is talking about surgery as an example of trouble with prostate, with the erections after prostate cancer treatment. These slides kind of emphasize the entire concept that it's all about your nerves. That's not really a theory that I espouse. Removal of your prostate actually hurts the blood flow to your penis. So most people that are in the know in the robotic era of surgery know that we spare your neurovascular bundle all very beautifully, and still everyone has problems with their erections for a fair period of time. So, but just know that that's going to cause immediate problems with your erections. Radiation will cause a delayed problem with your erections. Other treatments, they all will affect this to some degree. So anyone who treats prostate cancer should become a erectile dysfunction expert. And I think I am because of that. I'm going to kind of skip through some of these slides. These are in large part very old and propagandistic. I tell patients that everyone will have problems with their erections after prostatectomy. This is a very dangerous message to say some do, because then every man says, well, not me. And I don't find that to be a good message. The hope is that you'll get your erections back later after surgery. And in terms of, who does radiation affect? This is almost 100% as well, but it's a function of what time course you're talking about. Radiation will affect your erections in a delayed fashion. We're going to be talking about this actually at great length, by the way, because I'll be giving a talk soon on prostate cancer and the talk that I give patients when I diagnose them. So keep an eye out for that invitation. You'll see that on my website soon as well. And I'll talk about these things much, much more at that time. Just know that, the upshot of what I've talked about so far is, let's talk about erectile dysfunction as something that happens to almost every man eventually. Let's talk about erectile dysfunction as a progressive problem. It's, unless you're having a treatment for prostate cancer, it's something that comes on slow. It gets worse and worse until eventually you don't get erections. And therefore, we're going to talk later about treatment. And so, whereas it comes on slow and it gets worse and worse and worse over time, I call that in my practice the first hill of an old roller coaster. You're going to get up to the hill, you're going to do well. And at first, it's really slow. So when I'm dating myself, you have to be of a certain age to remember the old wooden roller coasters. But you're going up the hill, ching, 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 and you go real slow at first. But there's only one way. You're going to keep going, and it's going to get worse and worse quickly. Okay, and therefore the treatments we're going to talk about start real easy, and they're going to get more and more effective and more aggressive as you go. And that's kind of the paradigm here. Another thing that can cause Peyronie's disease. Let's talk about this too. What is Peyronie's disease? Peyronie's disease it's basically a problem where there'll be some scarring of your penis. And it can be very minor. It can just be a little indentation in your penis, all the way to, it can look kind of like a curly fry at a fast food restaurant. Most of these are very minor situations. When I see a man that comes in to say, I have Peyronie's disease, actually the first thing I'm doing, just like the man that says I have low testosterone, is I'm trying to figure out, is he talking about a bent penis that he can't use? Or is he saying, I have a little scarring and therefore that's why my erections are terrible? Because there is a tendency for men to want to look for a different reason. Oh, my camera just started working. For a different reason other than aging. Peyronie's disease can cause problems with erections. It's true. You'll have to have a harder penis to get hard when you have scarring. But usually, all I have to do is get those men erections, and then they're happy. And then we never talk about Peyronie's disease. So again, this is something to talk about, and it can contribute. I think there'll be a slide here. Here's a bent penis. If you had a scar right here, those two shotgun barrels can't expand in that one place, so it curves around the scar. If it's bad enough, you can maybe see, if this scar went all the way across, you might see that blood can't go in here, and so that could be the problem. But again, erectile dysfunction, normally this person isn't necessarily coming to see me. I mean, this one might, because of how bent it is, but they're not coming to see me because of the Peyronie's. They're really coming to see me because they have problems with their erections. And I usually focus on that, get them good erections, and say, we can talk about Peyronie's disease later if you're still unhappy. Doesn't usually come to that. Just worth talking about. So I've kind of summarized this for you. I'll just summarize it again. It's incredibly common. It happens to almost everybody in our society. It isn't like you're telling your friends at a cocktail party that you're having trouble, any more than you're going to say, my wife isn't as interested as she used to be, which is a ubiquitous statement to all marriages. Everyone thinks the other guy must have perfect erections and I don't. Everyone thinks that the other guy is having intercourse every night or every other night with their wife, which isn't true. And so I like to be that person that can give it straight to people, man to man. And the less one thinks that, oh, this is a problem for me and it means I'm weak, or it's an issue, and the more people just say, hey, this is important to me. I'm just glad there's easy treatments. Let's not worry about the psychological part of it. Let's just treat my erections. The happier people will be. And that tends to be my focus. Less so on the cause and more so on the solution. So let's dive into the solutions. I think I went the wrong way. Let's see. Okay. So I think these slides let's get these sort of out of the way first. I usually get the most questions about alternative treatments, and there are more. There is, I usually will get questions at the end of this talk about some, gels that people put on their penis with funny names. But these, and other hocus pocus things, herbal stuff, stuff that generally is sold on the internet without any, evidence whatsoever. But these are the ones people hear about a lot, especially shockwave therapy. And I've gotten fewer questions lately because for a long time there was an absolute media blitz on, medias that targeted men that were older or my age, such as, sports talk radio. The sports page in the Post used to have these big ads for something called the Boston Medical Group, which we can talk about, and just a lot of advertising for these clinics that used to talk about injections, which we'll talk about, and then it became way more lucrative for them to do something called this shockwave therapy. So let's talk about this. So shockwave therapy is basically the same concept as what we use for kidney stones, which is a machine that will fire pulsed sound waves to try to break up calcification. So you can imagine if we use such a machine to fire sound waves at kidney stones, they might crumble and pass. This is called a lithotripsy. And Siemens, which invented lithotripsy in Germany, thought, well, maybe we could do that first to Peyronie's disease. They tried that with Peyronie's disease. Now, of course, most of those scars are not calcified, so it doesn't help. But then there was an idea of if it is a blood flow issue, and if it is like atherosclerosis, where people say, I have atherosclerosis in my coronary arteries. I don't know how many of you guys have gotten what's called a cardiac calcium score, but the theory was if we fire sound waves at the penis, maybe it'll kind of break up the arteriosclerosis in those little penile arteries. And if that does occur, it might kind of induce more blood flow. And there was a little bit of excitement of this. And at this point, it's probably 15 years ago, because maybe there was one paper that NIH looked at, which showed that it may help some but only in patients who already have an excellent response to things like Viagra. So totally useless if your erectile dysfunction has moved beyond the phase where pills work, and we'll talk about that. They, of course, don't tell you that. They don't tell you that it's not going to work for you if Viagra works already. And really what I find is it's for men that really just don't want to admit that they're on Viagra. Remember, that's a weakness for them. That means I'm a dependent on Viagra and I'm looking for a fix or a cure. It's expensive. These places don't take insurance. I don't find them to be ethical, to be honest with you. And so a man might spend $5,000 on this treatment or more. And so when patients ask me about it, I tell them if Viagra already works for you, that's fine. But Viagra is cheap now. I for instance, sell it for $1 a pill in my office. And that means that's 5,000 erections for that man, that he could just take one every day. He could take it 10 times a day. And it would be cheaper than this. So I find that they take advantage of people that just don't want to admit that, look, I'm getting older. Give me my bottle of Viagra and I'll be happy. So I'm not a big fan of it. And I tell patients if they have a lot of money, such that losing $5,000 is no big deal to them, and if it'll give them a psychological benefit to say it helps me some so that I can sometimes now, perform without Viagra, then I say go for it. But for all other men, I say just get the pills. They're super cheap. What's the big deal? And that's the story. There has never been a paper recently that actually showed any efficacy beyond that initial paper. I've looked into it in great detail. So that's my story on that. And that's why I don't offer it. Intracavernosal stem therapy is entirely considered experimental. No evidence that it actually works or does anything. Same with platelet-rich plasma. So it's the kind of thing that these things, again, platelet-rich plasma is very popular in the orthopedic community. The thought process is that it's regenerative for things like cartilage. So they said maybe it's regenerative for the blood flow of your penis, and that's what that's about. It's expensive, and there really is no standardization. So they'll draw your blood, they'll spin it down, they'll take your plasma with platelets in it, but there's no protocol that's ever been shown to work. So everyone does their own protocol. There's no standardization. Doesn't make sense to me whatsoever. Same with the stem cell therapy. So those are things, again, where if someone says, I'd rather spend all the money to do that because I'm not willing to take Viagra. I do my best to try to convince them, just embrace the pills and be glad that they exist and be glad that they're cheap now. So we can answer more questions about that later if you wish in the different section. So now let's just look at the established treatment options. Okay. Now I guess they're talking about Peyronie's disease, and I'm going to sort of skip this. I'm not going to give injections, or I'm not going to do surgery on somebody for their erections. That's for sure. When we talk about penile implants, which is sort of the end of the line in terms of what I offer people, if you don't get erections and you have a curved penis, the go-to treatment absolutely is a penile prosthesis. But otherwise, I'm going to prefer to kind of skip over this again. If a man's seeking treatment for Peyronie's for his erections, I'm usually going to get them erections without treatment for Peyronie's, and they're usually happy with that. Oh, I think I'm going backwards here. Okay. Okay, so this is basically the progression. This is sort of a progression of what we have. So let's go over these one by one. Basically, I'm going to talk about pills, I'm going to talk about injections, and I'm going to talk about penile implants. I'm going to touch upon these very quickly, but I basically don't use them. I'll explain why as I go. But let's just give this talk right now. I like to just do this because I see this as a progressive problem, and it is a progressive problem. Step one of erectile dysfunction is the man says, I always used to get great erections. I never had any problems whatsoever. I don't even know what you're talking about. Never failed. Could do it 2 or 3 times in a night, like when he's young. And then the first thing is someone says, well, I have to work at it a little bit, but I can get it done. Okay. But he notices a change. That man just wants reassurance, and commonly will say, I'm not ready to step into the notion of pills because it's considered kind of a step for them. Then the time that a man is going to ask me to be treated is the first time a man loses his erections and can't finish intercourse. That's going to be horrifying. That won't happen all of a sudden. That's going to be, well, he always was noticing he had to work at it. And then eventually that happened. It's embarrassing. And once it happens once, it's in your head. You can't get it out of your head. Your wife or your partner or your husband or whatever is worried. And now they're thinking they're not attractive. It's a relationship issue. It turns into this whole relationship thing. I'm hoping some of you can commiserate with what I'm saying here, but and the key there is just to get an erection and move on, and no one has to know, and it's no big deal. So that's when someone's generally going to ask me for pills, when they fail the first time. Now, the important thing to know about pills, these days we're really talking about Cialis and Viagra. They are generic now. So Cialis is tadalafil. It was marketed as lasting longer. It's not really going to last 3 days for an older guy. The good thing about Cialis is that it doesn't matter what you've eaten before, that you take it. Viagra is something that everybody knows. Viagra is more quicker on, quicker off. Generally, that works way better for the older person who's married, generally knows when the green light might be on, when the red lantern might be hanging, doesn't need something that says it's going to last for 3 days. But really, they work very, very similarly. They have mildly different side effects. The key to understand, and they're all cheap. If they are prescribed, insurance can still play games with pills. They can still try to limit the number of pills. They still sometimes have rules that harken back to when these pills were $60 a pill not long ago. So it's rare to find a urologist that ever uses insurance, that ever tells you to go to CVS for these things. Like I said, I try to sell them very reasonably for $1 a pill at office. I'm going to soon start offering them as mail order for $3 a pill, still way less than everyone else does. They can be gotten very cheaply, even cheaper than $1 a pill if you're willing to use coupons and go through the hassle of telling the pharmacy about things like goodrx.com. I recently, dove in and said, I'm going to go on a statin and I'm going to, do that. And I remember standing at the Safeway pharmacy and thinking, this would be kind of embarrassing if I had to show them my GoodRx thing for my Viagra with all these ladies standing behind me. So pretty much everyone gets them from my office, I find, when they see me. The key to know about pills, though, is that eventually they will stop working. This is something that is lost on men. Eventually they will stop working. It's the roller coaster. So they're going to be good for the first part of the hill of the roller coaster. That's step one. But there will always come a point where they're no longer reliable, where they're not as good. Maybe you take a half of one and then you have to take a whole one. But there's always going to be a point where they stop working. And that's a very important take-home message from tonight. Oh, okay. So what do you do if the pills stop working? Okay. So we can talk about these two things. Nobody uses these anymore. I don't use these anymore. Let's start here. What do that? I'm going to do that, but I'm going to do it this way first. So the urethral suppositories are called Muse, medicated urethral suppository for erection. It's almost of historic significance. I used to be the national spokesman for this company. It's a small pellet you put in your penis. Very good if you've already been catheterized for prostatectomy. Tends to burn, is very expensive, isn't that effective, and has to be refrigerated. So it's very rare to find anyone that uses this anymore. Vacuum erection devices is basically a vacuum tube that goes over your penis, and then it sucks cold blood in. That's why the penis is blue here. Women, your partners are not going to feel as if it's a normal erection. It's cumbersome. You have to put a band around your penis, which only is going to stay there if you're really skinny. And so I've not really found this to be that effective. I had done a big national study on the use of this after prostatectomy. So the next step is injections, and we'll get to that. And then it's going to be penile implant. I wanted to do this so I could just dispose of these things. So this is going to allow me to sort of zip through these other treatments. Oral medications, they basically they dilate the arteries in your penis in an indirect way. Okay. These aren't really, how effective they are has to do really with why you're using them. And they have some side effects. And if one has a side effect with one, you switch to the other. But now let's dive into the injections. Everyone is thinking, oh my God, injections, that's terrible. I'm not going to be able to do that. You can see here, you have to inject the side of your penis with a needle when you want to get an erection. So, so I always say to men, you have a decision to make. You have to decide, do you want this as part of your life or not? And this is the go-to. This is what is done when pills stop working. People don't talk about it. You don't see TV commercials about this. But in the days before Shockwave, when those, clinics that take advantage of you decided it was much more profitable to have you do Shockwave, you would hear these ads for clinics that would guarantee success or it would guarantee an erection. And what they were selling were shots, and they were ripping you off because they were pharmacies basically that weren't telling you that you could get it for 1/10 the price elsewhere. So, so that's always a problem for me when people spend that money for that. It's very easy to do. Our nurse practitioner shows you how to do it. We have a very, very detailed tutorial on my website that talks you through what is done. And what I think gets people to do it is shots work almost every time. They do cause the 4-hour erection if you do something irresponsible. Pills never do. Everyone's heard of that. And approximately 40% of men discontinue the therapy, and that might even be higher than that. It's probably not 40% in my practice. But the reason is they haven't really decided, and this is so important, that this is a problem that I have. I don't want this problem. I'm committed to not having this problem. If they view it that way, they will embrace injections and treatments beyond. People are all willing to take a pill, but sex becomes less and less important as you get older. They may not be willing to dive into something like this. Generally, in my practice, I'm going to really push people to try this before we talk about anything else. It can hurt. We have to be careful that you don't use too much. That's why we teach you in person. It can create scarring, but it's quite rare. But that is the next step. Take home message: shots are the next step after pills stop working. Sorry, I keep going the wrong way here. I'm going to skip over this because it's something that if someone says, I'm just simply not willing to do shots, and if they're married and they're comfortable with their partner, and they're generally not comfortable with this, that's something these days you just get off Amazon. Again, this is Muse. No one uses it. Not worth talking about, to be honest with you. The only reason Muse is worth talking about, to be honest with you, is that what the medicine in Muse is the original medicine that was used for shots. So just so you know how it works, they said, well, the shots work. What if we put the pellet in your urethra to make that work? And it was a great idea. The problem is that active ingredient, which is called alprostadil, it hurts, which is why these shots that we use are generally a mixture of 3 different medicines, and only a third of it is alprostadil. And that's why you tend to get this pain and burning, and it's no good. Plus, it doesn't absorb properly from your urethra. So just to go back to that. So let's say you've tried shots. Shots usually work, but usually over time, if it's an aging phenomenon, and I tell almost all my prostatectomy patients to embrace shots, because the thing about prostatectomy is that that's going to be aging in reverse. If we think about that roller coaster going downhill, then you can think about what surgery is. It's putting you all the way on the second hill. You're going to be all the way at the bottom of that hill overnight. The difference is if you had good blood flow beforehand, if you got good erections before the surgery, that in 9 months to a year, you start sort of recovering. So you go back up the roller coaster hill. So you're going to go from nothing to then it's just you need shots. Then it might be you need pills. And in some cases, you need nothing. So that's worth talking about. Surgery, you do that aging or the roller coaster hill in reverse. But if you're the standard person and you say, I took pills, doesn't work. I tried shots, and it could be I tried shots, I just can't get into it. I can't get my head around that. I saw a person today like that. Or I've been taking shots and the doses have been getting higher and higher and higher. The thing about shots is we can change the concentration of the medicine, but sometimes it's not just a blood flow issue. It's your penis also, the veins aren't working right. So it's just taking too much. It's not effective. What do we do for them? We talk about a penile prosthesis, otherwise known as a penile implant. So we're going to talk about that largely for the remainder of the talk. We start with reassurance. We go to pills. When that's not working, we try to introduce shots. When that's not either practical nor working, we move on to a penile implant. The take home is we can always get you an erection and we can always make you happy, but we're going to do it in a progressive way. I'm not going to offer a penile implant to anyone who hasn't tried any of these other things. No way. So let's talk about it. There is a movie on here, and I don't think it's going to work for us, but I think all I have to do is explain this. There's actually 2 different ways to implant a penile prosthesis, and there's pros and cons of both. I recently learned to do it a different way. Similar idea, though, and it has to do with where the incision is. Remember the 2 shotgun barrels we talked about? Well, what I'm going to do in an operation, so a penile implant is a surgery. It's an outpatient surgery. But what I'm going to do is I'm going to get access to those shotgun barrels, and I'm going to basically hollow them out. We don't, that tissue isn't working well to bring blood flow. and I'm going to hollow them out. And I'm going to, inside your own shotgun barrels, I'm going to insert these things, which are the cylinders. They're not going to fill up with blood. They're going to fill up with water, which will be contained within a balloon. This is showing a left-handed person, or is showing it implanted on the left side here. This is a man's bladder. Most people are right-handed, so it would be on the right side. The way I do it now is through an incision here, and it goes in the midline. But the idea is just knowing that there is a balloon where the water comes from, and then somehow the water has to get into these cylinders, and that's through a pump that's in your scrotum. If I do this in a way that's an incision under the penis, the pump goes in the midline of your scrotum. One of the reasons I like to do it from above is that I tend to put it on the side that you're handed. So if you're right-handed, I put the pump on that side. And then the idea is if you wanted to get an erection, because it's flaccid in the beginning, you just pump this pump somewhere between 6 and 10 times. Most people kind of work that into their foreplay, and this is going to get rock hard. It's not a function of if it will work, it's going to work. And when you're done, you have the same sensation typically. You press this button here, and then it goes down. Okay, so no one knows you have it. If you're walking around in a locker room, no one's going to know you have this. It's just going to look like a flaccid penis, but this is going to work every time. Okay, so this is why generally we always say the highest patient satisfaction rates are with a penile prosthesis. 90, and that's because these are people that are all motivated. They're not just saying, well, I'll take a Viagra if you give it to me for $1 a pill. Only motivated people should be asking for this. Only motivated people should be offered this. And this is a motivated person is going to be extremely happy with this. They do have to understand that there is going to be discomfort and some soreness for 3 to 4 weeks. That's something that is just normal. That is absolutely something to be expected. But when all that passes, it's going to work. The company is going to support their product tremendously. After this surgery, I'm normally having to meet the actual rep that was in the room in my office to help show them use it, to help show them how to use this. The way I do it now, they're generally using it within a month of surgery. And the other way, it's about 6 weeks. So I generally decide which one's better based on your anatomy. But the number one thing that I make everyone aware of is, and patients have to be aware of, isn't so much that they'll be kind of sore after surgery, okay, but that there's a risk of infection. So once I make sure there's not another slide about that, it's very important to understand that risk. It's not a tiny risk. It might be 3%, and it means you have to be ultra aware of that. If everything was going well and you're using it, and then 2 months later it starts to ache again, I want to see you immediately. It's the kind of thing that we know now that if we know there's an infection, we have to take all this out. That's the problem. If bacteria gets on this, antibiotics won't generally get rid of that. But I can salvage the situation if it's early. We actually put in something like this, which is an old-fashioned, I'm going to call it old-fashioned prosthesis, called a malleable, where it's always kind of semi-hard. You bend it down and you bend it up. And for a long time, this is what there was at the VA, and people used this. But if I can get to you early, I can put this in, you clear up your infection, and we can come back and replace this if you want, or you might be happy with this. There are two-piece implants. Boston Scientific does have a competitor. Generally, the problem with the two-piece, and the only thing you're really saving is that there's no balloon, which you don't know is there anyway. This is all internal. The problem is there's less water in the system. So there's kind of less getting soft and less getting hard. So I'm generally going to be doing a three-piece, and most people are going to ask about a three-piece. I'm just going to see what other slides there are about this. Again, it's an outpatient procedure. It looks like it wouldn't be a marvel of engineering, but it is a huge marvel of engineering. I'm old enough to remember the original implants where these weren't galvanized, these connections, and we had to put sutures and they'd fall off. The reason it's this color is it tends to be implanted with an antibiotic treatment. And so this really is high tech. 10 years later, sometime later, something can stop working and I'll have to replace that. I just replaced one. I just saw a 91-year-old man who wants it replaced. He's had it for 35 years and it stopped working. So that's kind of the hallmark. Just remember the risk is infection and erosion, infection and erosion. That's what I always say. And everyone has to be aware of that, not just as a cautionary tale, but they have to be aware of that so that they can let me know right away so we can salvage that situation. And this is talking about the two different ways. There's an incision that could be done under the penis or over the pubic bone. And that guy looks pretty happy. He must be beyond the four-week point. But people will be very happy with their prosthesis if it was something important to them. This slide is kind of important. Medicare patients have nothing to worry about. It's always covered and it's never an issue. It's usually covered by Blue Cross. It's oftentimes not covered by some of the other insurances like Aetna, United Healthcare, or Cigna. So that's before someone gets too excited about it. I'm commonly, going to schedule the procedure and then start the insurance coverage process and going from there. It is expensive if it's not covered. So that can be a barrier. We fight and fight and fight, and there can be assistance options. So it's always something we should talk to. Around here, most people have Blue Cross or Medicare. Generally, there's nothing to worry about there. They're just going to say, I'm really happy. I'm not alone. I'm happy. Patient testimonials. And again, people are happy with it. If it's covered, it's totally affordable. It lasts a long time. It doesn't break easily. And bottom line is you'll be happy. It's the most spontaneous of all of these things. There's nothing in your bloodstream. You still have an orgasm, etc. And the risks, these are the risks, and it should talk about infection, 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 infection. So there it is, okay? They call it a 1.2 to 2.5% risk. I like to tell my patients 3 to 4%, just so it's front and center. Everybody knows about it. Again, here's a website that Boston Scientific uses. My website, dcurology.net, I think is a great place for you to learn more about this whole thing. You will find this talk there and many other talks. And at the end of the day, if you want to be this guy and have your wife look like that, you want to basically treat your erections and don't settle for this. I know it's embarrassing. Just say, let's fix it and move on. These are the bibliography entries that go into making these slides. So I need to show this to you. I'll just zip through because I'm not necessarily expecting you all to see it. But if you ever wanted to, you could look this up on my site. It'll be there. And the bottom line is this concludes the Boston Scientific section of this talk. And I'm done with these slides. I know I've kind of zipped through them. I wanted to kind of touch the high points. And we're going to stop the recording now.